Hello friends, today I am going to talk about the management of MI. Now the patient comes with chest pain, breathlessness, shortness of breath, pain radiating to his left jaw, neck, left arm. Then the first thing that a doctor suspects or relative suspect is a myocardial infarction, MI, or heart attack. Patient is rushed to the hospital. First thing that doctor does is stabilizes the patient, puts him on oxygen, and then takes the ECG immediately. Now the ECG will indicate that whether the patient is having a heart attack or not, or heart attack is because of acute or chronic condition. Because the management of acute and chronic, they are different. So the ECG, what indicates acute condition is STEMI, ST elevation MI. Now ST segment in the ECG, if it is remarkably significantly elevated, then we call it STEMI, or if it is not elevated, then we call it NSTEMI. Now STEMI indicates acute obstruction in his coronary arteries, and it needs to be managed immediately on urgent basis. Other parameters are like cardiac enzymes, which are elevated, pro-BNP, which is elevated. So now how you manage STEMI? STEMI is managed immediately by, if there is a cath lab facility of the cath lab, patient is taken to the cath lab, angiography is done, and then the culprit vessel is identified, and then immediately emergency angioplasty is done. That is how the patient is relieved within minutes. Now if there is no cath lab, then patient is put on pharmacological fibrinolysis drugs, streptokinase, tenecteplase. So these drugs, they dissolve the clot or the obstruction. Because the obstruction is because of acute obstruction, is mostly because of some plaque or some clot going and obstructing the vessel. So now that is how it is managed. Once the patient is stabilized, then patient is transferred to a facility where cath lab is present and his angiography is done, and subsequently decision is taken. Now in NSTEMI, patient is stabilized with oxygen, drugs, and then patient is sent to the cath lab. His angiography is done, and based upon the findings in the angiography, a decision is taken that whether the patient needs continued medical management or stenting, or he needs a bypass. Now most of the time patients and the relatives are inclined to the stent, because that decision becomes very crucial, that when doctor says that now you need to take the decision that whether you want bypass surgery or stenting. Most of the time this option is given by your cardiologist. So the decision that to choose between stenting and bypass becomes very crucial, and most of the patients and attendants, they are biased towards the stenting. Why? Because it seems a quick fix, less invasive, and less risk taking. But that should not be the approach. You should take a rational decision based upon the outcome and the benefit of the patient. Although stenting is less invasive, seems less risk involved, but what are the long-term outcomes of the stenting? Whether the vessel is suitable for stenting, whether the stenting will establish the complete revascularization. These questions should be asked from a cardiologist. Whenever your cardiologist says that okay, stenting can do, you should ask that whether it will establish the complete revascularization, whether the vessel is suitable for the stenting, and what are the long-term outcomes. because stenting, many times stenting becomes just the acute management or emergency management, and you return back to the hospital after 6 months or say 1 year, and then you are sick. Now you will have to go under bypass. So that should not be the approach. So whenever stenting is advised, you must ask the doctor these three questions: revascularization, vessel suitability of the vessel for the stenting, and the long-term outcome. Whenever your doctor advises you for multiple stents in the same vessel, or then you should ask what is the rationality of putting multiple stents in the same vessel and not going for the bypass, because multiple stent in same vessel means that vessel is not suitable for stenting. There are blockage at multiple level, and the bypass becomes a better option. Now similarly, the stenting advice for multiple vessels, again putting multiple stents in multiple vessel is not a very rational approach. You should always ask that will the bypass be a better option. So this is how patient and relative should get involved in decision making. You cannot because your doctor is only a guide. He will guide you, and actual decision is left upon the patient and relatives. So at that time they are confused and they get blinded by the risk involved and the less invasive procedures. And there is a myth that cardiac surgery is a very dangerous procedure, life threatening, and once you go under bypass, the outcome is not very good, and maybe that even the risk of death on table is very high. But these are all the myths of the past. Now cardiac surgery is very safe, and the chances of mortality in normal cases is only 1 to 2%, just like any other surgery. And when there is high risk cases, it varies from 2 to 5 or 5 to 10%. But again, even if it is as high as 10%, means your survival risk without bypass will be very less. So taking chance your 90% survival benefit is much better than living with less mobility, breathlessness, and frequent hospitalization. Thank you.